Well, good afternoon, and welcome to the pre-Congress workshop. We call it a pre-Congress workshop, but I like to think of it as the beginning of the Congress, and that everybody here has gotten kind of a head start in attending the Congress. So, welcome. It's a big room with relatively few people. If you don't want to move up, I still think that you should feel in a mood to be highly interactive. We would like to speak with you as well as with each other during the next hour, and we're going to cover a lot of ground during this workshop on the changing face of hepatitis C, new patients, new challenges. I'm Ira Jacobson from the Mount Sinai Beth Israel Medical Center in New York City, and my distinguished colleague is Professor Heiner Wiedermeyer, who you all know, and he will be presenting along with me. This will be a case-based format as well as featuring one main lecture by Professor Wiedermeyer. These are our disclosures. I have to say that I think Janssen, to put this together, found the names of every company that I've worked with for the last 30 years. I am not currently working with all of these companies. I don't know about Heiner, but somewhere in here are the companies that I'm working with at the present time as well. And I do want you to know that I do other things besides work with pharma companies in my life. So we're going to have a detailed discussion with an attempt to understand the potential shortcomings and risks of current hepatitis C therapies. We'd like to explore what the patient population with hepatitis C will look like in a few years and how this will impact treatment and patient care, and examine the potential advantages of 3-drug versus 2-drug direct-acting antiviral combinations. It goes without saying, of course, that we're in the midst, as we've come to say so frequently, of a revolution in hepatitis C therapy, a very important development in the entire field of medicine in general, but one must not think that the entire field has been solved. There are still, as implied by the topics here, some very important issues that we have to talk about, including the potential shortcomings even of these miraculous therapies that we have. And we have to have strategies to capture all the patients eventually so that this disease goes away in due course. This is our agenda for today. I'm making just a few introductory comments, and then the main lecture will be presented by Professor Wiedermeyer on the changing face of hepatitis C, in accordance with the title of the symposium. We prepared 2 cases, and we'll interact with each other, but again, we hope with you as well, and then we'll have a brief summary toward the end. There will be people walking around with microphones. If you do have a question in the middle of the workshop, just please raise your hand and somebody will come over with a microphone. And hopefully at the end we'll have a dedicated few minutes during which we will answer your questions. We'll also have some interactive voting, and instead of the usual format of A, B, C, D, or 1, 2, 3, 4, Janssen has given us a gift of some beautiful color cards that you have in front of you, and when the time comes, we'll ask you to hold up the color that corresponds to your vote when we give you the multiple choice questions. I think you'll enjoy that. And with that, I'd like to introduce Professor Wiedermeyer, who'll talk about the future treatment of hepatitis C. Heiner?
Thank you very much, Ira, for the introduction. Dear friends and colleagues, I also have to thank the sponsor for asking me to be involved here, and I thank you for coming early to the Congress here. Many friends, many faces. We have quite some attendance, Ira, from South America, so hopefully the cases that we discuss will be interesting for you as well. I think so. The scope of this symposium is to look a little more in the future of HCV treatment. We have seen a dramatic change in the landscape and treatment algorithms throughout the last 2 years. We have a very diverse situation in different countries. It's now a little more getting similar between countries as drugs become available more and more. But still, time is evolving rapidly, and we are already now looking beyond the next 1, 2, 3, 4 years. And this is the aim also of this symposium. We will discuss current issues in extent during this meeting, and here we want to set the stage. What is present right now? How do we deal with cases? But which options may even further then arise over the next 2, 3, 4 years? So why are we here? Why we're talking about hepatitis C, and we have seen many slides highlighting the disease burden caused by hepatitis C virus infection. The most recent, let's say, semi-official data generated by the Global Burden of Disease study was presented at EASL. You are aware of the Global Burden of Disease study, and the last data for 2013 were published in January 2015 in the Lancet. And when you then have a closer look to the HCV data presented in this Global Burden of Disease study, you can see here, I think, really dramatic figures, which also reflects our clinical impression. When I started in hepatology and I was on a ward in Hannover Medical School, from time to time we had a patient with hepatocellular carcinoma. When I went for the round yesterday, half of the patients in our liver clinic actually had liver tumors, either HCCs or CCCs. And this is reflected here by the green line. Also, this dramatic increase in HCV-associated disease burden. HCCs are increasing, and the mortality increased by 292%. And the overall estimated mortality due to hepatitis C in 2013 was 700,000. So it's really a very high number, which highlights why we need to work on this, why we need to make sure that the patients at risk of dying need to get access as soon as possible, but also to look even further, imagine how these numbers would look like in 5, 10, 15 years if we do not take action now. Then you have seen these models developed by Homi Razavi, and in a series of papers, these graphs were created. What I like about this model is that, let's say, the same algorithm was used for different countries. So modeling is great, but it was quite hard to compare different papers because there were always differences in the model, disease progression, etc. So the good thing is that this was used throughout countries. I just picked here figures for European countries, and already at this picture you can see how different the disease burden is between countries. So we are not talking about Egypt versus Australia versus Brazil versus US and Europe. This is Europe. And look how the figures look like for France versus Spain versus Germany. So completely different epidemiology in these countries, different ages of the patients, but also different cofactors. So alcohol consumption in England is different versus France versus Spain. And therefore, these issues have to be considered, I think, also in the management of hepatitis C in future. The good news is we have disease burden associated with HCV. We can do something. We have treatments. We have, in the year 2015, SVR rates of 95 to 100%. And the experience that we had in clinical practice, this is really true. This year in 2015, with the latest regimens at Hannover Medical School, we have treated a couple of hundred of patients. I have seen 2 relapses, 2. In this case, I've referred relapses from other doctors, but these numbers are really impressive, and the most important thing is that they are really safe. We need more registries to look in more detail whether there may be rare side effects that come up, but these drugs are very well tolerated. Then obviously what can we achieve by these new drugs? And this is again the models by Homi Razavi. You have seen, most of you, these figures. So the black line, the top line would be if we would have continued our practice in 2013, so SVR rates of 50%. Then the green line would be higher efficacy of the drugs, 90% of SVR estimates, but the same number of treated patients. And the blue line would be also to increase treatment uptake, which differed between countries. For Germany, for example, in this model, the increase was only 75%. So it's not tripling or doubling or five-fold increase in treatment uptake. It's just 75% increase. And with this, for example, we could eliminate HCV in Germany by 2025 about. So these were the good things, and the tool, and this will lead to reduced cirrhosis rates, reduced HCCs, reduced liver-related deaths. You have seen this, so it's worthwhile to achieve this goal. And which tools do we have to achieve these goals? We have the 3 different targets with 4 different classes of drugs, which have been introduced during the last 18 months in various countries around the world. the protease inhibitors, NS5A inhibitors, and polymerase inhibitors. Sofosbuvir became available, approved by EMA in January 2014. Then we had Cimaprevir approved in May 2014. We had Daclatasvir approved in late August 2014, and Lidipasvir, Sofosbuvir in November. And then we had the 3D regimen, Paritaprevir, Ombitasvir, Dazabuvir, approved in January. These are basically the tools that we have available in Europe. There's also Azunaprevir in combination with Daclatasvir available in some countries, including Japan. So this is the portfolio which we have right now and which will be discussed during the next 2 days, during this meeting and during AASLD in extent. We see more and more real-world data. We see subgroup analysis of specific patient cohorts. And the current issues that we will discuss during this conference are diverse. We have really tough decisions ahead in many patients. The question is when to start. Should I wait? Should I treat now? What's about fibrosis level? Only F3, F4? Should we include F2, F0? This is something to be discussed different from country to country. What should we use? We have these regimens I just showed before. Is regimen A better than B? Is only price deciding? Is only cost deciding? Are there other issues to be considered? Then the big question, how long? I will talk about treatment duration in a minute. And it's wonderful that we have something to discuss and to fight, whether we should use ribavirin, yes or no. So when we left AASLD, ribavirin was dead. And then, EASL 2014, ribavirin was dead. And then at AASLD, there was a resurrection of ribavirin. We loved ribavirin and we can use it. Will resistance be an issue? This was the hot topic of EASL. Suddenly it's in the brain again. Advanced cirrhosis, impaired renal function. What should we do for genotype 3? Do we have the optimal treatment yet? These are the issues we are fighting, we will discuss. I will not go into detail in this symposium, that you will not be tired over the next 2 days. The aim of this symposium is to look beyond this. Which issues will we have and will we face in 2018, in 3 years from now? So imagine what is our topics to be discussed at that time. I don't think that we will talk about transplant patients in 2018. I proposed an internal grant proposal to Hannover Medical School, to the board. We have a special center grant 2 years ago and 3 years ago, and then I said, okay, the overall goal of this project is to eliminate HCV from the transplant cohort by 2018. And then I had one reviewer, this is completely unrealistic, you are please revise the grant. And I revised the grant half a year later, and I said, okay, I propose to eliminate HCV by the end of 2016 from this cohort. This was not very well received, but in the end, I could convince this reviewer. Advanced cirrhosis may be a problem in some patients, but not as it is right now. Right now, we have to treat all advanced cirrhosis. So the most severe patients, the majority should have been treated by 2018. We will see patients, but then we'll know better also what to do. G3, hopefully no longer a big problem. I'm not 100% convinced yet that all the new drugs will completely solve this problem. HIV co-infected patients also should not be a major issue in 2018 anymore. Which issues may we face in 2018? We still will talk about how long to treat, simply for cost reasons. How much can we reduce treatment duration? 8 weeks, 6 weeks, 4 weeks in some patients. Treatment as prevention will be a topic. We will see treatment failures, even maybe not in a large frequency, but the more patients we treat, the more patients we will see who fail treatment for either virological reasons, but also non-virological reasons. They have been exposed to drugs, and we have to give them an answer what to do next stage. We will still have distinct patients groups. I didn't call them special risk groups or special patients. I called them distinct patients groups, which we have to talk about. We have then also to monitor the clinical long-term outcome of interferon-free therapies. Is really everything getting better or not? So it's good. I think we are all convinced it will prevent people dying from liver disease, but maybe we have to look also for extrahepatic things. I just had a patient, the very first patient that we treated in the Sofosbuvir early access program post-liver transplantation, sometime in 2013. I was mentioning this case before. He started treatment. He was post-transplant, 85 kilogram. We cured HCV. Everything is fine. I had him on my ward some weeks ago, but not for liver problems. He had completely uncontrolled diabetes. He had a weight of 120 kilogram, and now I'm wondering whether I did a good thing in curing HCV if he's now dying from a heart attack. So, and these issues I think we have to face in 2018 in the future. And then obviously we have to think about diagnosis and have to make sure that access to therapy is guaranteed. So which drugs will we have in 2018? I showed you the ones approved. We will have them still in 2018. And they will also put pressure on the price of the new drugs because they have to become cheaper, and then it will be quite interesting, the price battle in 2018, because there will be additional drugs to those that I showed you. We have programs which are still ongoing and where phase 3 trials are either already completed, and we have seen the data at EASL, or are close to be finished. So the Merck Gratzopirvir-Elbasvir program, which has been submitted to the agencies, and we have this Fosbuvir, and then GS 5816, which has a name now, Velpatasvir, and there also the phase 3 trials are ongoing. So these drugs we will have, but we will have additional second-generation drugs from each class, from protease inhibitors, we will have polymerase inhibitors, we will have NS5A inhibitors, and many companies are developing additional compounds with improved efficacy across genotypes, across RAFs, which are covered by these drugs. And then there will be the big question, will be interesting, whether some of the companies who are still running additional targets, whether they will continue, yes or no, whether we will have additional targets in 2018. For example, entry inhibitors, for example, drugs targeting miRNA 122. We have seen data, early clinical development data at EASL for these targets. Will be interesting whether they will continue, yes or no. At least the proof of concept in animal models that this can work has been made. It's very interesting. We will see whether they will proceed, yes or no. And the specific drugs for these classes which have been presented at EASL, which I found, so don't accuse me, company representatives, if you don't see your specific second-generation drug listed here. I apologize for that one. I just screened the EASL abstracts and then listed some of these compounds, and they are listed in alphabetical order, also not to grade this, but I'm sure I missed something. But just to highlight you that we have protease inhibitors, that we have NS5A inhibitors, that we have polymerase inhibitors, NUCs in development, and even a non-nuke that was presented at EASL. So we will have additional tools. Which one of these programs will really make it, yes or no, we will have to see, and phase 2 trials are ongoing. So what will be discussed in 2018? How long will we treat patients? 2 years ago, I think most of us would have argued, well, chronic hepatitis C cure in 4-6 weeks, is this possible? We would have laughed. We have seen the data during the last year, during the meetings, that short treatment is possible. The first trial was presented at AASLD, the triple combination, so Gratzopirvir, Elbasvir plus Sofosbuvir. And you can see here that 6 weeks was possible in non-cirrhotic patients in the majority of patients. And then it was always shown as a failure, this trial, that 4 weeks will be too short, but I would have put it the other way around. It's remarkable. 10 out of 30 patients cured HCV within 4 weeks of therapy, which is remarkable. And I think we have now to find out which are those 30%, where we may even further push the level and shorten therapy and save costs. This will be interesting, whether we come to a really personalized therapy based on treatment duration. And there are other combinations which have been presented at EASL. So Ed Gain presented for the Gilead combination therapy, and similar picture also here. Some patients made it with 4 weeks, but 6 weeks seems to be possible in a well-selected cohort. And we have seen also data for the Achillon compound. This is only a dual combination, so the previous were always triple combinations, so protease inhibitor, NS5A inhibitor, plus nuc. I'm destroying here the equipment, sorry about this. Plus a nuc, while even only 2 drugs may make it for 6 weeks, which I think is interesting. You have a very strong and powerful NS5A inhibitor, which with a good resistance profile, then even 2 weeks may be sufficient, which I think 2 drugs may be sufficient, which I think is really remarkable data. To what extent this will then reflect clinical practice, we have to see whether we go for 8 weeks as standard and then with some regimens push it a little. It's something to be seen, but I think my prediction would be that 8 weeks will be something of standard duration, and then we will play from 6 to 12 weeks depending on the patient profile. What I really like is this idea. So why do we need shortened therapy? Who cares if I take my drugs 6 or 8 weeks? I don't care. I will cure them anyway. What would be interesting when we talk about cure, elimination of HCV, then obviously compliance is an issue, delivery of drugs. And what about the idea to put these 3 drugs together in a different pharmacological formulation and to cure HCV with 1 or 2 drugs? So if I have the 3 classes with a pharmacological profile, they stay in the body for 6 weeks, then I need 1 injection, point of care testing, 1 injection, HCV gone. This would be my dream. Is it possible? Yes, it is possible. There are trials in HIV ongoing with once a month HIV meds injections. It's possible. So pharmacologically, it's ideal. Now you may ask, why do we need this in the hell in HIV, where I need lifelong treatment anyway? Where it would make sense to me would in HCV, that we can really eliminate HCV. You go into rural areas, inject 1 shot, and then HCV is gone. Just a thinking, maybe in 2018 a little too early, maybe 2020, 2025. I don't know if companies jump on that idea, but I like it. Okay, then we come, and this leads me to the next point, treatment as prevention. Is it reality? And obviously we have this interferon-free combination therapies. We have 90 to 100% response rates, and can we now use these wonderful drugs not only to prevent disease progression but also new infections. And then we made jokes over the last 1.5 years. I just want to attend an EASL-ASLD symposium, which is so tiring and damn boring, with 95, 97, 99%. I want to see the 105%, right? We were always laughing. It's not a joke. It is true. We can have a trial with 105%. I will prove it to you. So how does it work? You have HCV-infected patients. Let's consider an IV drug cohort. You give them one of the new Wonder regimens, and you cure 95% of the patients. And then you're remaining with a smaller group of HCV-infected individuals. If this would be a high-risk group, which, let's say, over a period of 3, 4, 5 years, would transmit virus to others, HCV negative, certainly by treating these patients, you would reduce the potential source of infections, and you also would reduce the number of transmissions with this treatment as prevention. So if you then come up with a cohort of 1,000 people in a certain setting, you treat all of them, you cure 950, and you're left with 50 HCV-infected patients. If this, over a certain period of time, if they would transmit it to 100, then obviously this transmission would be reduced from 100 to 5 transmissions. So we would have prevented 95 cases of HCV. So if you then come up and sum up with these numbers, you have treated 1,000 patients and you cured or prevented 1,045. And this is certainly above 100%. So an SVR above 100% in high-risk populations is possible. And this is basically the concept of treatment as prevention, while we should consider this in distinct risk groups, in distinct cohorts, IV drug users, men having sex with men, and there are various ideas in various countries. I just attended a workshop on HCV eradication. For example, in Georgia, they have the idea to eliminate HCV from that country by aggressive treatment, and there are various other settings where this may work, and I think this will be the topic in 2018 that we will discuss. However, one concern is certainly reinfections, but maybe then also transmission of resistant variants. Is this possible? Is this a concern? And there have been one case which has been published last year in Gastroenterology. So this is certainly what we have to watch. If these IV drug addicts, if they are less compliant, if resistant associated variants emerge, that they can transmit it to others and thereby also impairing the likelihood that they respond to treatment. This is something which we may need to watch very carefully. I do not think now that this will become the major issue and topic in HCV, but I think we have to keep an eye on that. And if this is a concern, this leads me to my next point. If resistant can be transmitted, so what do we do with these patients? How to deal with retreatment need of DAA failures? I don't want to go to all the data presented at EASL. And resistance came back into our minds. What have I learned at EASL? First of all, resistant associated variants are there already, even in untreated patients. Depending on the genotype, depending on the class of drugs, so NS5A versus NS3, you can estimate that 10 to 15% of patients carry already a RAF. It's there. And these RAFs differ. This is also when you see presentations, don't consider RAF as RAF. What we also learned that the level of resistance conferred by a distinct mutation matters in terms of responsive rates. So, for example, for the Merck regimen, it was 5-fold less or more, which decided whether you should treat 12 or 16 weeks in non-responding patients. And for the lidipasvir thing, it was 100-fold, what Christoph Sarrazin showed. So the level of resistance, the type matters, and therefore what you all have to do, and we will have the examine outside when you leave the room. I am showing you a case on all these distinct variants, and you have to remember these names. So Q93, Y, and M, and this is something where you have to become experts in, because they may matter. Or you have an app in future where you just type in this distinct one, and then the app tells you what you have to do. Because these RAFs may, in certain settings, guide treatment decisions, treatment durations. So right now, if I would be a genotype 3 patient, where I would consider a treatment with an NS5A inhibitor and sofosbuvir, and I have liver cirrhosis, I would do a baseline RAF screening, and we would guide treatment duration based on the presence of distinct NS5A RAFs on the data which I know right now. The problem is that if you fail, they persist after therapy, and in contrast to HCV NS3 resistant RAFs, which decline over time, the NS5As persist. However, and this is interesting, what we have also seen, it's not very simple virology that if a RAF is there, this class does no longer work. We have seen that retreatment with the same class or even with this identical regimen can lead to a sustained response in some patients. So we have seen in the target cohort that tenofovir, boceprevir exposed persons can be retreated with simiprevir. It's possible, even with lower response rates, but still reasonably high, 60–70%. I don't know if someone of us would have guessed this 2 years ago, that a tenofovir failure retreated with simiprevir would lead to that high response rates. The same holds true for the NS5As. We have seen this. And you have to keep in mind that certainly some of these resistant-associated variants may become of less of importance with the next wave of drugs that will be introduced during the next 1 to 3 years. So just some data conferring really that the NS5A RAFs persists. This is from the lidipasvir trials, and even 2 years later, the majority of patients carried these RAFs. They were detectable. However, retreatment was possible, and Ira will show you a case related to this question, and so keep an eye on this one. So the question is really if a patient has been exposed 8 weeks or 12 weeks with lidipasvir sofosbuvir and then has been retreated, then the response rates really differed. So previous duration matters and the type of RAFs mattered. So retreatment is possible. We'll see more data at AASLD, and this is certainly one of the most relevant questions for the next 12 months where we have to give an answer to our patients. We will discuss this, and the hope is that the next wave of drugs, next generation, both for NS3 as well as for NS5A, are better in covering distinct resistant variants. This is data presented at EASL that the Achillon NS5A inhibitor in vitro covered most of these rafts, which were basically in vitro not covered by ledapasphere or daclatasphere. And you can see here these numbers. I don't want to bother you, but start learning these specific numbers. You will deal with this in future. What about distinct patient groups, special risk groups that we called them before? Which are the patients we will discuss in 2018? I think we need options for children when we talk about treatment as prevention, when to start this. This is something which is an issue because it will be impossible to study all of the drugs in children. We don't have enough children to follow the regulatory guidelines, and I'm really concerned that we need to take action on this one with our pediatric colleagues, that we will at least have a reasonable number of drugs available for these individuals. And the same holds true for the elderly, which have not been studied well. We need the registries. We have seen some data on the above 70. We need more data on the above 75, 80, whether these drugs are safe. We have different pharmacology in the elderly. We have to study this one. Whether some genotypes may persist there, we don't know yet. Genotype 6 carries NS5A resistant variants. Whether the new drugs cover genotype 3, we will see. Renal impairment may be an issue. We will see still patients with multiple co-medications where drug-drug interactions may be an issue. So we will have something to talk about in 2018, but I think this is less of importance. What will be important is to determine and to monitor really that the clinical long-term outcome is effective. I gave you already the example of this patient who really had weight gain, and so the non-liver symptoms may become important. We know from the interferon-treated patients that curing HCV is a good thing. This is the frequently quoted Adrian van der Meer study showing that all-cause mortality, in addition to liver-related mortality, is reduced in patients that achieved an SVR based on interferon therapy. And he also showed that those patients with cirrhosis who clear HCV have a normal life expectancy. So on the left side of this graph, you can see these SVR patients who started off with cirrhosis, cleared HCV, and they were matched to the general population of the Netherlands, really showing that you can normalize life expectancy. The problem with this study, however, is that this was a strong selection bias because this included only patients that fulfilled inclusion criteria for interferon. And the question obviously is, what would be the effect of curing HCV in patients not fulfilling interferon treatment criteria? And there have been many patients not treated for two reasons. Either they were too healthy, they didn't have liver disease, or they were too advanced, and this was not differentiated. We are going to submit a paper very soon from a German cohort where we had this third group, and you can see here that the survival of this untreated patients followed by general not practitioners, but gastroenterologists in private practice, that they were worse in terms of outcome, and will be very interesting to see in future what the clinical effect of interferon-3 therapies will be in this specific group of patients. And this is something we have to watch and talk about in 2018. That there is some hope that we indeed are doing some good things. We're seeing now the first data. You have seen the SOLAR 1 and 2 data, one published in Gastro, 2 presented by Michael Mentz at EASL. And we have seen data that also surrogate markers, albumin levels improve. This is data from the AbbVie regimen doing follow-up. And we have published our own series in Hanover, so advanced cirrhosis, child B, C patients, AP and T recently, where we could see that various liver function parameters all improved, but with distinct kinetics. So albumin improved faster. Other markers took a little longer time when they improved, and we also saw, similar to the other cohorts, that MELD scores improved in the majority, but not in all patients with advanced cirrhosis. And I'm sure that we will see more data at AASLD on this issue, so we have to watch this in the long term. And finally, obviously, we have to work in 2018 when we have, let's say, hopefully treated the majority of patients with advanced liver disease on the hope for eradication of hepatitis C, which was picked up more than a year ago by the media already. And to achieve this, we need to work on completely different things. We need point-of-care testing in rural areas where we have immediate access to a test that we can tell the patient. The biggest thing is a problem in many settings is that the patient will not come back 2 weeks later to ask what was the outcome of my HCV test. We need point-of-care tests, not only for antibodies, but also for HCV RNA. In some settings, we may also use other tools like dried blood spots, and you can even quantify HCV RNA from these dried blood spots, which I think is very interesting. This paper went online from Jean-Michel Pawlowski's group and Stéphane Chevalier just last week. We have to keep an eye on that one. Other tools like HCV core antigen testing can be explored also in antiviral therapy without interferon, and that this is very old data by various groups that this correlates very nicely with HCV RNA, even though with less sensitivity. The other issue, obviously, is I mentioned the diversity between countries. Migration is an issue. I've been asked this morning, what does Germany do for the immigrants now coming to this country? Do we have a regular screening for hepatitis C, for hepatitis B? And I can tell you in this country, for the very first time since 25 years, we have in 2015 an increase in acute hepatitis B cases reported to the Robert Koch Institute. It was declining for 25 years with the vaccination, and this year, I'm also interested in hepatitis E. I was hoping that we would overcome, or that we have more acute hepatitis E cases than hepatitis B cases for the first time in the history of this country, but it is not the case because we have a sharp increase in acute hepatitis B cases in this country. And this is something which we have to face, so we need to talk about completely different things: training of specialists, training of GPs, point-of-care testing. These are all the issues, and obviously we need to make sure that access to therapy is guaranteed with reasonable prices. We need special programs for resource-limited settings. We need treatment as prevention, and we need, in the end, national action plans to fulfill these ambitious goals. In 2018, we will have many options, great times, but I think it's all a responsibility for all of us to really work on this goal to eliminate HCV. Thank you very much.
Thanks very much, Heiner. That was a panoramic view of the whole field in 30 minutes. And we have a couple of cases to go through to illustrate some of these points. We have the case from my practice of a 57-year-old gentleman with longstanding hepatitis C, genotype 1A, whose liver biopsy in 2008 showed METAVIR F2, septal fibrosis, and at that point he unfortunately failed to respond to peg interferon and ribavirin. But when telaprevir came out 3 years later, he took a course of that, and things looked good during the course of therapy, but unfortunately, he relapsed afterward. In January 2014, when he was reevaluated, he still had evidence of relatively mild or at most moderate fibrosis with a FibroScan score of 6.3 kilopascals. The FibroSure perhaps predicting a little higher grade of fibrosis, but still clearly not cirrhosis at 0.58. His ALT and AST were modestly elevated with the ALT higher. His albumin and platelets were normal, and he had a moderate HCV RNA level of 850,000 IU per mil with an ultrasound that showed no evidence of cirrhosis nor of focal lesions. Because he had been exposed to a protease inhibitor, and because in the US at the time the only DEA combination that we could access, albeit FDA unapproved in early 2014 still, was cimeprevir and sofosbuvir, we did a test called a GenoSure in the US, NS3 sequencing, and he had the Q80K, which, as you know, is present in about 50% of American genotype 1A patients, but less commonly here in Europe, perhaps 15 or 20%. He also had a variant called the V36L, but as shown in the footnote at the bottom, this is actually not associated with reduced activity of cimeprevir. And with regard to the Q80K, I would remind you from the phase 3 Optimus 1 and 2 studies that the Q80K with a cimeprevir-sofosbuvir regimen, at least in the context of a 12-week course of therapy, did not appear to impact the efficacy of this combination in non-cirrhotic patients, though it did in cirrhotics. Because of the fact that he'd been exposed to a protease inhibitor and not having the Optimist 1 results available at the time, we elected to defer therapy in this non-cirrhotic, hoping for an upcoming regimen of an NS5A inhibitor plus a nucleotide or perhaps something else. Hopefully I haven't biased your answer to this question, but this is the first chance to show the color cards. I would ask you to consider how you would treat this patient at the present time. Would you give ledipasvir, sofosbuvir for 12 weeks, ledipasvir, sofosbuvir plus ribavirin for 8 weeks, decladisvir, sofosbuvir for 12 weeks, or umbidisvir, paritaprevir boosted by ritonavir, dasabuvir, and ribavirin because the patient has genotype 1A for 12 weeks. As you know, patients who get that regimen with genotype 1A require ribavirin to optimize their SVR possibilities. So how many people would vote for ledipasvir, sofosbuvir for 12 weeks? The red color?
Red color,
Okay.
some of you,
Yeah.
in our direction.
And
Poland, one would not do this? You would, okay.
and what about the yellow color? Ledipasvir, sofosbuvir with ribavirin for 8 weeks?
Raise the yellow colors, nobody, okay.
No yellow colors, okay. And indeed, you're not supposed to do that. That's only for treatment-naive non-cirrhotics with low viral loads. Decladisvir and sofosbuvir for 12 weeks, which you've had available here in Europe for a longer time, and I think many would say is biologically equivalent to ledipasvir, sofosbuvir. And then the 3-drug plus ribavirin regimen. Any takers there? Okay. So you would give that regimen even though the patients had a protease inhibitor, and that's
So
fine.
you're not concerned, Robert, that he was a protease exposed? Okay.
Okay.
May I ask you one question?
Of course.
When we one back, you did this resistance testing. Is it in the US easily available? Can you just submit it? And
Yes.
maybe the colleagues from Brazil, do you have the resistance testing available? Can you look for both NS3 and NS5A variants, or is it a challenge? Maybe if you have a test available, can you use a green card? Show you who has a test for available. Who could send right now? And resistance test away. Show us the green card. Few of them. Who cannot do this? Who cannot send away some resistance? In the UK, you are poor guys over in the island in the North Sea, so no option to test for resistant variants, and some other ones. So not everywhere, and they're also not. Okay.
Okay. Well, we can do both, but the NS5A resistance testing only became available about 6 months ago. As you know, the NS3 testing was available for the last couple of years, as shown by this history. At the beginning of this year, literally on New Year's Day, the patient began a course of ledipasvir and sofosbuvir at the appropriate doses with the fixed-dose combination pill, had a wonderful virologic response, and by week 12 was not only undetectable, but had normalized his ALT. Unfortunately, by follow-up week 4, the virus was back, and obviously that was confirmed at follow-up week 12. A very disappointed patient. I think you've said you've had 2 failures to DA therapy, and that's exactly how many we've had. This is one of my 2.
But the amazing thing is here, this patient has usually would expect a relapse in a, I don't know, a cirrhotic patient, overweight, all factors, but at least what I saw here, he was not, well, he was male. Kilopascal was 6.3,
Yeah.
so it was not really expected. Most likely, I don't know, bad IL-28B genotype, right, with the interferon failures. Anything else? Overweight, compliance, we ask them always, if this fails, do you believe that he took the pills? At least, apparently, yes.
I firmly believe all of my patients take their pills, but I think we all think that about our patients.
I never believe a patient, but
Yeah. In ION-2, the treatment experience study with ledipasvir, sofosbuvir, there were a very small number of relapsers in the 12-week patients who didn't get ribavirin. Interestingly, there weren't any relapses with ribavirin, but the numbers were very small and it wasn't a statistically significant difference. So what would you do next? And would you give an NS5A inhibitor plus sofosbuvir with or without ribavirin for 24 weeks? Let's do it one at a time. Would anybody give that? Maybe you need a moment to digest the other choices. Any red cards here?
you can use it twice if you do once after the other. So who would consider the red option, so an NS5A plus soft for 24 weeks, a reasonable option? In Brazil, you would do this. Huh?
Plus riba.
With riba,
Okay.
so everything.
Would anybody consider simepravir, sofosbuvir with or without ribavirin for 24 weeks?
Some yellows from Janssen people. And not only.
I would remind you that we've had 2 real-world database presentations in the past few months that have shown that the responses in telaprevir or boceprevir failures with simepravir, sofosbuvir was surprisingly good.
Yeah.
In the target study, there was a little bit of a decrement of about 10% compared to patients who'd never taken a protease inhibitor. In the TRIO, which is a pharmaceutical, a very large database in the US, there was no impact. Nevertheless, my bias is still to avoid protease inhibitors in PI failures.
But I think it's a reasonable question because you have just recently exposed this person to an NS5A inhibitor, and this person will have NS5A RAFs present at this stage. He has been exposed to leprevir. He will still carry most likely Q80K, but other additional mutations should have been disappeared meanwhile after this 2 or 3 years. So in terms of really, let's say, relevant RAFs, most likely the NS5A would be there, and in terms of NS3, just the Q80K.
Mhm.
So it might be an option, right?
It might indeed. How many of you would order if you had it, let's say?
If you have it.
Pretend you had it. How many of you would do as the very next thing an NS5A sequencing test? So a number of green cards,
Yeah.
particularly in that part of the room, and a couple of others. And how many of you would make up your minds at this point in this non-cirrhotic to simply defer therapy until a more pangenotypic or broad-spectrum coverage regimen
Okay.
has
So
been developed?
Brazil, UK, Poland, and other countries would defer it, which is reasonable, right?
Yeah, what would you do here?
I would
you-
wait.
You wouldn't get the sequencing test?
I would sequence them, but then the question is really, what is the consequence at this stage?
Yeah.
If I know that there is a Q whatever K variant, either. So I've just answered this morning a similar question. Identical case, 12 weeks, not pre-exposed to boceprevir. What would you tell? And I told him. Hopefully, I will see more data. The point is certainly I have data for soft riba retreatment for 24 weeks. We have this data. We have a soft lidipasvir 24 weeks, but it's still not 100%. This patient has been exposed to 12 weeks and has no cirrhosis, and we will have additional drugs and data. So at this stage, I would wait. And 24 weeks of soft lidipasvir, this is a cost burden, which is also something to keep in mind if you're not 100% sure.
All right, well, we all have never-ending curiosity, so I ordered the NS5A sequencing test, and he had, Professor Craxey, how are you? And he had 2 resistant variants, the L31M and the Q30R. These are known variants that can emerge after exposure to a first-generation NS5A inhibitor. Professor Wiedemeyer already showed you this very nice slide, which illustrates several fundamental points. You see here the EC50s, or concentrations needed to suppress virus in vitro systems to a given degree, in this case by 50%, and the fold changes. And you can see, first of all, that not all NS5A inhibitors are created equal. As Heiner alluded to in his very nice talk, we do have the possibility, as shown in the first column for ACH3102, the possibility of NS5A inhibitors that cover a broader spectrum of resistant variants than the first generation counterparts, although it still has that one Achilles heel of the Y93H, which is probably the most resistant of the variants to the NS5A class. We've put in red the 2 variants this patient had, the Q30R and the L31M, and although ACH3102 is quite active with very little of a fold shift in sensitivity in vitro, you can see marked fold shifts for ledipasvir and decladisvir. And I think that this data that I obtained from the NS5A sequencing test facilitated my ability to decide that re-exposing the patient to a first-generation NS5A inhibitor, again, probably wasn't the way to go. And therefore, we decided to defer.
Even though, coming back to the last slide, the key question will be really to what extent these in vitro data then in the end will translate into in vivo differences in efficacies. And it's interesting, and to some extent it's true, but also all the data that we have seen for the other drugs, you are sometimes surprised, I think.
Yeah. Heiner, I'll just ask you, for the sake of time saving, what you would do here. Would you now defer therapy given that information? That's what you were inclined to do before anyway.
Yes.
Okay. I think most of us would agree with that. And this is a slide showing 2 studies on what to do with people who failed sofosbuvir. On the left, we see patients who failed either sofriba or peginterferon and ribavirin, who do wonderfully when they get ledipasvir and sofosbuvir. They haven't had a previous exposure to an NS5A inhibitor and therefore haven't had the opportunity to develop resistant variants, or at least have them emerge under the effects of NS5A inhibitor therapy. On the right, we see a very impactful study presented by Eric Lawitz of patients who had failed ledipasvir and sofosbuvir for either 8 or 12 weeks, showing that when retreated with ledipasvir/sofosbuvir for 24 weeks, would have loved to see a randomized trial with or without ribavirin,
Yes.
so that question remains unanswered. Relatively small numbers, to be sure, but the theme here is that the 8-week treated patients previously did better than the 12-week treated patients. And I think the big number everybody took away that you've already emphasized, Heiner, is the 45% in the patients who got the 12 weeks of therapy. And this turned out to be related to the fact that the patients exposed to treatment for 8 weeks had not had the opportunity to evolve resistant variants, or at least not the same complex profile of resistant variants or the same degree of highly resistant variants that the patients exposed to 12 weeks of ledipasvir had, and that's why they did better. You can see in the third pair of bars on this slide toward the left that with regard to baseline NS5A RAVs, the retreated patients who had no baseline RAVs, baseline that is at the onset of retreatment with their 24-week regimen, all of them were cured compared to only 60% of those with baseline NS5A RAVs. And the RAV makes a difference. Heiner, I think, emphasized appropriately that we as clinicians need to become a little more familiar with this terminology and with the implications of each of at least the common resistant variants than we may have thought we would have to be at the beginning of this era. But it really does matter how many RAVs you have. As you can see, patients with 2 or more RAVs fared more poorly in the dark blue bar. And then on the right side, the RAV itself matters. These are patients who had single NS5A RAVs. Some had dual RAVs, but that's not this analysis. And again, the Y93H emerges as the most ominous actor on the stage, so to speak. Here's a slide, a study from Barcelona, a resistance workshop just held 2 months ago in June, looking at cimeprevir/sofosbuvir for 12 weeks for prior NS5A inhibitor, that is decladisvir, failures in a couple of different regimens, but they'd been exposed to an NS5A inhibitor. You can see very high SVR rates, 87%, although there were 2 treatment failures, both with cirrhosis. The genotype 1A patients encompassed the 2 patients who failed, but the numbers were bigger, so you can't really compare 1A to 1B and draw any conclusions that the genotype 1 subtype makes a difference. And then for extra value, there were 2 genotype 4 patients who were successfully retreated. So I think at the present time, this is a viable consideration, as we suggested before in the multiple choice question, for patients who have failed an NS5A inhibitor plus sofosbuvir. So NS5A RAVs are usually detected in patients who fail prior NS5A inhibitors. Actually, with 12-week treated failures, these RAVs are almost invariably present. The degree of resistance conferred by these RAVs differs. Resistance testing for NS5A is now available, and I think is appropriate for NS5A failures, though as Heiner aptly pointed out, we still don't know what to do with that information. We don't have randomized trials showing that if you pursue one course as opposed to another based on NS5A resistance testing, that we have robust data suggesting that there's one particular regimen. Still, I think the information is useful. I think the longer duration of the same regimen is suboptimal, but we still need to study the impact of adding ribavirin, which might enhance the SVR rates to some extent. And it may be better to retreat first-generation NS5A inhibitor failures with another class like a protease inhibitor, in addition to sofosbuvir. Remember, sofosbuvir in particular, and probably nucleotides in general, are the class to which you can be re-exposed. Although there is such a thing as emergent resistance, it's very seldom seen across the sofosbuvir development program and in real-world studies. And finally, more advanced NS5A inhibitors, as we've discussed, with broad coverage of these resistant variants, will have an important role, we think, in the retreatment of NS5A failures, whereupon they may revert to becoming the standard initial therapy as well. Heiner, why don't you quickly go through your case,
Yes.
because I think there's a lot of value there.
Okay, so I wanted to discuss with you a very, very simple case, which you all see, and this is Peter. Peter is a patient that has also other problems. Later on I will come to this, but we have to keep in mind certainly that treatment indications go sometimes beyond liver problems. You have autoimmune problems, you have fatigue, but you also have social and legal consequences. So you have the issues about getting a health insurance, being HCV infected. You have other issues in terms of sexually transmitted diseases. They are all issues that we have to keep in mind. So Peter is 46 years of age. He has been using has been injecting drugs. According to FibroScan, he is somewhere now, according to F2, so 7 point something, close to 8, and then he has a genotype 1a, cryoglobulins are positive, and he is under methadone substitution. And the very easy question is, would you treat this patient, yes, now? Would you need more information to decide, or would you simply say, okay, F2 fibrosis, not now, later? So who would treat this patient now? Some Greens in the UK, you would treat them right now. Who would not do this? No need for liver disease, no red cards here. So my colleagues in Germany would frequently quote a red card now, I have to say. Who of you need more information to decide to treat? You have everything already? And who would defer treatment? Any blues? You're very aggressive. I would say if I would pose this to a German symposium right now, I would get 80% blue cards at this stage. Why to treat this drug addict right now? F2 fibrosis only, we can wait. Let's first treat the liver, cirrhotics, etc. Your arguments to start early, obviously, is reflected by the compliant. He has a regular job. He shows up on time. Liver disease is borderline, let's say. So he has normal bilirubin, he has significant hepatitis, intermediate viral load, and he is absolutely stable on methadone for 14 years. So there's not a major issue. Now my question is, again, to all of you, I slightly changed the profile of Peter. So would you still treat this patient? Absolutely no fibrosis, almost no biochemical hepatitis. So raise your cards again. So who is for green, red, or blue? So at least I see one red, and the others would still treat them. 2 reds now, meanwhile, and some blues around there. So now some of you would be willing to wait. Interesting. And what's about this profile? Compensated cirrhosis, ALT, AST ratio deferred, who would treat now? I still see red cards. One of them, but now you would treat. So I think we will agree with that one.
The red became green.
Yeah, the red became green. Sorry, other way around. So, but now, coming back to the initial Peter with F2 fibrosis. So what's about this? He's drinking, let's say, a social borderline amount of alcohol, so 15 to 20 units per week. The other problem is that, obviously, in terms of compliance, we note actually in our patient charts if the patient shows up on time, which we don't see at the doctor. So I ask a nurse always, did he show up on time? And he missed 2 of the 7 last visits. So he's not that incompliant. You can turn it the other way around. He made 5 of 7. It's good. So in the UK, you would still treat him. Yeah? You give it to, so he missed 2 of the 5. What about the other one? Brazil no longer answering here. So what guy, you guys from Brazil, what do you want to do here? You still treat them. It's interesting. Some of them need more information, so it's borderline here. But this is what we are facing right now. And again, my German colleagues, the majority would give him a red card at this stage and would ask them more to show up. The other point, obviously, is extrahepatic manifestations, and this is the reason why I saw Peter, actually. He had cryoglobulins, he was under stable methadone substitution, and he also had impaired kidney function, and obviously this is a no-go. Please raise your green card. We all agree that this patient needs treatment, and we have to see what the outcome will be. But this is the reason why I saw this patient. But highlighting really how difficult it is sometimes. Tiny little differences in lab values, in social habits may guide our treatment decisions, which I like with this case when you play with small variables. And obviously the attitude to address these kinds of patients may be significantly different in different settings. So what would you have done?
Well, I would certainly treat him even if he had F0 fibrosis because of the cryoglobulinemia.
And what about this missed visits? How would you have deal with this issue? So 2 out of 7 visits missed? How
I would worry about it, I would counsel him accordingly, and I would try to get a partner or a spouse in the office with him
This is a
who
good
might wield an iron fist.
This is a very good, I think, recommendation. So always take the partner. This was in interferon times even more important. I think now it's less important, but I agree with that one. This is a good recommendation. Yeah. So, okay.
So before we finish, I have a question for you. Thank you for that case. You mentioned in one of your very first comments that when you go around your wards now, that half the patients have cancer. And I think I heard you allude to cholangiocarcinoma as well as HCC. I think we all know there's that connection, but I dare say many people probably haven't actually seen that. How much cholangiocarcinoma are you seeing with hepatitis C?
So it's more and more, and there is the epidemiological data really linking also CCCs to HCV, and I can recall in our clinic at least 15 cases, HCV-associated CCC. So it is there, it is a problem. And often in histology you have this mixed type of tumors also, which are, let's say, CME, HCC, and then also have some CCC parts in this one.
And these are intrahepatic cholangiocarcinomas, right?
Yes.
Not of the main bile duct, common duct.
All intrahepatic. This is important.
Heiner, are you getting baseline resistance testing in DAA naive patients at all?
Let's say we have no, let's say, broad commercial tests. We have the labs which do it in Germany, so I don't do it in the treatment-naive patient at this stage. I do it in every treatment failure.
Okay. Other questions from the audience? We have a microphone right here. Yes.
That's cool.
Can I just ask, with the benefit of hindsight, your patient, he'd already failed PEG-RIBA, he then failed tolacavir PEG-RIBA. With the benefit of hindsight, would you perhaps have added in ribavirin to that third course of treatment? I mean, the evidence is not hard, but I have to say, when I'm on a third course of treatment for a patient, I would sort of chuck everything I've got at it. I'm just interested to know.
As a matter of fact, I'm going to say something unorthodox, which is that the answer is yes. After this patient and my one other, who was similar, relapsed, a prior treatment experienced non-cirrhotic who didn't get ribavirin, I looked again at the ION-2 data, and I recalled something that I mentioned in passing before, which is that there was a small percent of patients who got 12 weeks of latipizivir sofosbuvir in that study without ribavirin who relapsed. It was 4 or 5% compared to 0 without ribavirin. So I said to myself, gee, if ribavirin seems to help the cirrhotics, at least in terms of shortening treatment duration, a theme that we'll talk a lot about at the Congress coming up shortly, maybe it might add value to an occasional non-cirrhotic who's an interferon failure. So I started to add ribavirin, but most people are not doing that, and I'm not giving that as a blanket recommendation. It's just something that we've started to do. Your thoughts?
Absolutely, I agree with that one.
Interesting. Okay, well, we'd like to thank you very much for attending this pre-Congress workshop. We'd like to thank Janssen and Achillion for sponsoring the program and for their support of the Congress. And please do remember to complete the evaluation forms that are in front of you on the desks. These will be looked at carefully and used to enhance the value of future programs. Thank you very much.
Thank you.